hand over to Dave.
Thank you, Emily, and tēnā koutou katoa, everybody, and thank you for joining me for this evening update on gout, which has been run through Arthritis New Zealand, and so thank you very much for joining me. I should introduce myself. I've worked for Arthritis New Zealand for getting on for 11 years now, and prior to that I worked as an orthopaedic nurse at Dunedin Hospital for 4 years, and prior to that I worked in Liverpool. As you can probably tell, I'm not originally from New Zealand. I worked in Liverpool for about 15 years on an orthopaedic trauma ward, so that's my background. But for the past 11 years I've worked for Arthritis New Zealand, and part of my role is to talk to people who are affected by all these different kinds of arthritis, and to try and give them some information and advice about what they can do about it. So part of what we've done is actually put together some continuous development programs for health practitioners, which is what we've done here. We've also got another one, fibromyalgia, as well. So hopefully we'll be doing that at a later date. So this is on management on gout, and so I'll launch into the presentation. Hopefully you can all see the screen and you can all hear me all right. I'm sure Emily will put me right if we've got any technical issues. So okay, let's go on to the next slide if I can. Cool. All right, so first thing to say is I'm not a rheumatologist, and so before we put this presentation together, we talked to one of our rheumatology colleagues, Dr. Rebecca Granger, who some of you might be familiar with. She's one of the consultant rheumatologists up in Wellington. So I thank her for clinical oversight of this presentation, and also like to thank Emily, who you've already met, who's providing our technical support. So thanks very much, you guys. This is what we're going to be looking at this evening. So basically, we're going to be looking at a description of gout. I'm sure this is not going to be new information for some of you out there. Some of the risk factors, the situation in New Zealand. New Zealand, as some of you might know, has got the worst rate of gout in the world. So we lead the world with gout, so it's not a fantastic situation we've got here. We're looking at some of the diagnostic criteria, looking at treatment of acute gout, looking at the treatment to prevent future gout attacks, and then looking at the British Society of Rheumatology 2017 guidelines. And then following that, we'll be looking at what Arthritis New Zealand can do to support the patients with gout and also the health practitioners out there, and also looking at some other resources as well. So here are some learning outcomes. Hopefully at the end of this, we'll have an understanding of the factors that can contribute to New Zealand having such a high incidence of gout, and how the current management can hopefully be improved. An understanding of the diagnostic criteria, and understanding of current guidelines around the treatment of acute gout, and an understanding of the current treat to target guidelines on treatment to prevent future gout attacks, and an understanding of the support offered by Arthritis New Zealand for patients with gout. So part of this, we're going to have a couple of poll questions through the webinar. And this is the first one, and it's just basically to try and find out who the audience is. So I'm not sure. Hopefully you can see that screen there, and we just ask you to just tick whichever box would best describe your current practice. So I'll give you guys a few seconds to fill that in. Cool. So I've got a fair mix there. No physios, I see, but yeah, a good mix of pharmacists and GPs and practice nurses there. That's great. Thank you. So moving on. Couldn't really have a gout presentation without some nasty looking photographs there. So some of you may be familiar with this sort of thing. This is tophaceous gout, which is pretty extreme. Hopefully, most people you'll see with gout do not have it to this extent, but yeah, this is what can happen if gout goes unreported a lot of the time, and sometimes the treatment sometimes isn't adhered to either, so that can lead to all these sort of problems there. And we can't really have a gout webinar without a cartoon as well. Usually when people do presentations on gout, there's usually a cartoon in there. This is an old cartoon. Looks like it's from the 18th century there. And I'm not sure if you can see it, but what it says is punch cures the gout and the colic and the tisic. Now, I wasn't really sure what tisic was, so I had to read up about it, and it's an old archaic term for a cough. So yeah, I'm sure punch doesn't help any of those things, but I think it's quite important though to put this image there, because I think it sort of reinforces some of the myths around gout. And I think a lot of people out there still associate gout with overindulgence, eating and drinking too much, and I think that can sometimes make it difficult to engage with people. Yeah, I think sometimes people think that they've brought the gout on themselves, which is not helpful really. So we're trying to remove some of the stigma around gout, because, as I'll mention, it's primarily a genetic condition. So I'm sure this isn't new information for a lot of you guys out there, but I thought it'd be helpful just to go back and just look at what gout is exactly. And so what we've got here is that gout is a form of arthritis caused by the inflammatory response to intra-articular monosodium urate crystals. And yeah, a lot of my clients who I talk to aren't even aware that gout is a form of arthritis, so that's quite interesting. So yeah, it's just good to reinforce that really. And in early disease, gout presents as recurrent episodes of self-limiting acute inflammatory attacks or flares of arthritis. Commonly, these attacks affect the first metatarsophalangeal joint, midfoot and ankle, so somewhere in the foot, but not always. But that's where the common presentations are. And in the presence of prolonged hyperuricemia, some patients develop recurrent polyarticular attacks, so more than one joint, can sometimes go on to develop chronic tophaceous disease, which is what we had a look at before with those photographs. Sometimes erosive arthritis and renal disease as well. So yeah, people can get problems with the kidneys and uric acid stones, kidney stones forming there as well. So here's some risk factors for gout. Hyperuricemia, obviously, that's what's causing this. Male sex, I can't remember what the ratio is, I think about 3 to 1, I think, if I remember rightly. More males than females will have gout. Maori and Pacific ethnicity, and we'll look a little bit more about that, and the reasons behind that. Chronic renal impairment, so anything that affects the kidney's ability to excrete urate can cause gout. Hypertension, obesity, and diuretic use, and coronary heart disease. Okay, so looking at the New Zealand situation there, these are 2014 figures, but I think the current figures probably wouldn't be much different to this. I'm not sure if you can see my cursor, but what strikes me here is that, well, a couple of things really. First is that the risk for females under 65 is quite low, and then as soon as we jump over 65, the risks goes up in all these ethnicities. And so I think it's quite rare to see gout in premenopausal ladies. So that's quite significant, I think. Also, some of these percentages here are huge. So if you look at Pacific males over 65, we've got 46% who have gout, which is huge. And so this is one of the reasons why New Zealand's got such a massive gout problem, and Maori as well, not far behind there. So yeah, absolutely, it's a huge problem in New Zealand. I'm not sure if you can see this very well, but this is just an attempt to show you the geographic spread. You might be able to see the darker colours are where there's more of a prevalence of gout, and you'll see that Northland, South Auckland particularly, is probably the gout capital of the world. Hawke's Bay, Gisborne, these are all areas where we've got a lot of gout. Probably not surprising. There's been attempts to look at the genetics of gout, and they've been doing some really great research down here. Actually, I'm actually running this webinar from Dunedin, and at Otago University, Tony Merriman is one of the, and his team down here at Otago University have been looking at the genetics of gout. And one of the things that's been discovered is that there are a couple of genes, variations in genes, which can actually increase the risk of gout, and in particular a variant called the SLC2A9 gene, and that increases the risk of gout by more than 5 times in Maori and Pacific peoples. And there's also a variant of the ABCG2 gene, which increases the risk in European and Pacific peoples, but not in Maori. You'll see that there's some references here. I will put the references up at the end, so all these references here, you'll be able to see them at the end of the presentation. Okay, so just looking at a natural history of gout, what can happen to some people. Asymptomatic hyperuricemia, so people have got too much uric acid in the blood there, and that traditionally has remained untreated with medication. It's asymptomatic, so the patient probably hasn't got any idea, unless they have a blood test, that they've got hyperuricemia. But if it is identified, it probably does give us an opportunity to talk about the possible diet and lifestyle changes, and also look for some possible underlying causes of the hyperuricemia as well. And the figures here are of people with hyperuricemia, 20% of those will go on to develop acute symptomatic gout. So normally, a typical attack of gout would be involving one joint, but it can also be involving more than one joint, so polyarticular. And without specific treatment, an attack is likely to resolve, usually within 7 to 10 days. But in practice, usually the severe pain that can come with that usually does get people to seek some sort of relief. But if it's non-treated, then it seems to go away, which can probably accounts for why it's underreported a lot of the time. And then it can go on into critical gout, and the length of time between attacks can vary widely. Some patients may only ever have one attack, but the majority will have a second attack within the year. And if the serum urate remains high, and what we mean by that is greater than 0.36 millimoles a litre, then there can be ongoing joint damage and tophi formation as well. So tophi are those horrible lumps that you'll see on the skin there. And then if untreated, you can end up with chronic tophaceous gout. So tophi are these firm, like these little white translucent nodules in connective tissue, arising from the deposition of urate crystals there. See, there's a typo on my presentation. And as well as causing joint destruction, tophi can be quite disfiguring, and actually can alter people's function as well, particularly on the hands. One of those pictures we saw at the start there showed tophi on the hands, so it obviously can be quite limiting for people. They can become infected and inflamed, and can also exude tophaceous material, and some of you may have seen that. It's quite unpleasant. So looking for a diagnosis of gout, there's some this is quite old really, but this is the American College of Rheumatology Wallace criteria, which I found. And what it says is, when you're trying to diagnose gout, probably the gold standard really is looking for the presence of urate crystals in the joint fluid. So that usually means a joint aspiration, or a tophus proved to contain urate crystals by chemical means or polarized light microscopy. So, but I think in most general day-to-day practice, it's probably not necessary to do this if it's a typical presentation. But if there's any doubt, then it might be something to think about. Or There are other criteria, 6 of the following clinical criteria. So maximum inflammation within the first day. So it's usually can be quite a sudden onset. More than one attack or of acute arthritis. Monoarticular arthritis, so affecting one joint. Redness observed over the joints. First metatarsophalangeal joint pain attack. Unilateral metatarsophalangeal joint attack, unilateral tarsal joint attack, so these are all in the foot there. A suspected tophus, hyperuricemia, asymmetric swelling within a joint on X-ray, and negative bacterial culture of joint fluid, because sepsis is the red flag here. So according to those criteria, if your patient's got 6 of those, then they've got gout. There have been some more recent attempts to classify gout. This is something called it's called a sugar. It's abbreviated to the sugar study. And yeah, the details are there for anybody of you who want to dig into that a little bit more thoroughly. I did have a read of that paper. It's quite complex, but the message I got from reading that was that ultrasound, joint aspiration and visualization of uric acid crystals and ultrasound seem to be highlighted as the best ways of diagnosing this condition. You'll probably, for those of you who got access to the community health pathways out there, the web address is there. I know this has been rolled out throughout the country. This is the Canterbury one. But if those of you got access to this, you will find some really great information about assessing. This is just the assessment page, and at the top there, it's got the red flag, which is septic arthritis, which is obviously what needs to be excluded, because that is a medical emergency. So it can look like gout though, so it can be quite difficult to tell one from the other. So I thought I'll put some imaging up there, if that's helpful. So this top scan here is an ultrasound, and I'm not very skilled at interpreting these, but I'm told what this shows is something called a double contour sign of the hyaline cartilage. So that is, I guess that's what these things are here, and that can be a sign of gout. And this is something called a dual energy CT scan, or a DECT scan. And what it shows in green here, you might be able to see that there, if you can see my cursor, and there in the Achilles tendon is urate deposits there. This is plain X-ray, and you may be able to see, you can get these characteristic punched out erosions in the bone. So hopefully you can see that there. So that's on plain X-ray. So imaging can be quite useful. So here's a treatment summary for acute gout. The first thing to do is exclude sepsis. I'm told by my rheumatology colleagues that if you aspirate a joint and you see that it's cloudy, then it probably is going to be infected, and obviously you would send it off to the labs. But I'm told that joint fluid should be clear and sort of straw coloured. So you can tell a lot just by looking what comes back into the syringe. And once you've excluded sepsis, then the recommendation is to prescribe a non-steroidal anti-inflammatory for the pain and inflammation, and advise rest. I'm told that gout is probably the most painful form of arthritis there is. So obviously pain relief is going to be a big thing that your patient's going to be grateful for. And if non-steroidal anti-inflammatories are contraindicated and the infection has been excluded, then consider corticosteroids, either oral or into the joint itself, or colchicine. And if further pain relief is required, consider combination treatment and recheck the diagnosis as the other recommendations there. So excluding sepsis is really important, but it's also important to realise that you can get gout and sepsis at the same time. And the presence of urate crystals in synovial fluid does not exclude a diagnosis of sepsis. So although hyperuricemia is a key risk factor for gout, it's not sufficient to make the diagnosis of gout, because only about 20% of patients with hyperuricemia will develop gout. And serum urate concentrations can be normal in patients during an acute gout flare, and we'll look a little bit more about that. So, you know, some people will say to me, you know, Dave, I've been to my doctor, and you know, they've done a blood test and they told me I haven't got gout. I'm thinking, well, yeah, okay, yeah, the blood test in itself is probably not a good way to diagnose it, but obviously something that should be undertaken frequently to check serum urate levels. So this is what rheumatologists will talk about, is treating to target. And what they mean by that is to try and aim for a target serum urate of below 0.36 millimoles a litre. Although the more recent British Society of Rheumatology guidelines suggest a lower target of 0.30 millimoles a litre. So perhaps the 0.36 millimoles a litre isn't ambitious enough. But as I'm sure a lot of you guys know, non-adherence to urate lowering therapy, allopurinol, can be a challenge. You know, a lot of my clients will actually say, oh, yeah, my doctor's put me on allopurinol, and oh, I take it when I get a gout attack. And I'm thinking, oh, yeah. So there's obviously some education to be done around that. So the question is, when should urate be tested? It doesn't really matter what time of day it's taken, and it doesn't have to be non-fasting. It doesn't have to be fasting. But up to 40% of patients with an acute gout flare may have urate within a normal range at that time. So that's quite a lot of patients with gout have got a normal urate level blood result at the time if it's taken then. And if urate is not elevated at the time of the flare and gout remains a possibility, it's probably a good idea to repeat the test once the flare is resolved. And for individuals with confirmed gout, urate should be measured frequently, and the suggestion is monthly during initiation and escalation of urate lowering therapy. And once the target urate is achieved, it should be tested probably every 6 to 12 months to ensure ongoing maintenance of urate control. So those are some of the guidelines there. So allopurinol is usually the urate lowering therapy of choice, and still the first choice in most cases, unless it's contraindicated. It's a xanthine oxidase inhibitor, which probably means a lot more to some of you guys than it does to me. And dosing can be difficult, and ideally it should be calculated on estimated glomerular filtration rate. So this is showing an attempt to show you how allopurinol, and febuxostat as well, operate. It probably makes more sense to some of you guys than it does to me, I have to say. It's but it may be interesting to see. Obviously, it acts on the pathway there, purine synthesis. These I'm not sure if these are available in New Zealand. These are some other treatments there, but I've not heard of those. I don't think they're available here. So this is the suggesting starting dose of allopurinol, and as you can see here, we've got estimated glomerular filtration rate on one side and the starting dose there. So hopefully this will be a bit of a guideline for you guys if you're thinking about starting someone on allopurinol. So I'll leave that up on the screen for a little while, and but this webinar is being recorded, so if you wanted to go back and check this information, then you probably have an opportunity to do that. So that it's just showing you that it's really, and I think most rheumatologists, when they talk about starting allopurinol, they say start low and go slow. That's usually the advice that you get from a rheumatologist when starting allopurinol. And I think the advice has always been to not start allopurinol during an acute attack of gout. But I remember talking to Rebecca Granger about this, and she said that she does actually start people on allopurinol during an acute attack because it may be the only time she gets to see them, and that's probably a common problem, I guess, is that you might be the only opportunity you get, because a lot of people are not very good at reporting problems with gout, as you guys probably know. And so she says in those instances, if she suspects it might be a while before she sees somebody, then she will actually consider starting allopurinol during an acute attack, but it's probably not the usual thing to do. So adverse effects with allopurinol, most common side effect is a rash. Probably affects about 1 to 2% of people, and probably more common in patients with some renal impairment. But then there's this allopurinol hypersensitivity syndrome, which is quite a fearful thing, really. It's very rare, but can be potentially fatal, and it's characterized by fever, rash, eosinophilia, hepatitis, and renal failure. And these adverse effects can occur at any dose. So just things to be aware of there. Colchicine, it's quite an old treatment. The problem with colchicine, it's got a very narrow therapeutic margin. So if you take a little bit too much, you end up with all these toxic effects, including diarrhea, nausea, and vomiting, and electrolyte imbalance, alopecia, hematological effects, pancreatitis, and failure kidneys and liver and respiratory system. So yeah, and I am aware of cases where people have died from taking too much colchicine. So and this is a natural therapy, and I think it's derived from autumn crocus or meadow saffron, I think. So this would be considered to be a natural treatment. That just shows you that not everything that's natural is necessarily safe. Probenecid, some of you guys may have some experience with this. Using this is a uricosuric agent. It's effective for an effective urate lowering drug if people have got normal renal function and under excretion of urate. Can be used in combination with allopurinol if there is a persistent hyperuricemia, despite therapeutic doses of allopurinol. But I'll talk a little bit more about therapeutic doses of allopurinol. Or in allopurinol intolerance. And typical dose for probenecid is 250 milligrams twice a day for 2 weeks, and then up to 500 milligrams twice a day. Probenecid is contraindicated in patients with a history of renal stones. And if people are on probenecid, they need to make sure they have a high fluid intake. So that's that. Febuxostat is a newer urate lowering therapy. I'm sure a lot of you guys have got some experience of using it. Dose does not need to be adjusted in mild to moderate renal impairment. So a creatinine clearance of greater than 30 mils a minute may be more effective than a fixed dose allopurinol, and appears to be well tolerated in older patients. But there are some risks with that, as there are with most things. Our main risk is liver problems. It may also increase cardiovascular risk. Hypersensitivity reactions, again, as with allopurinol. And prophylaxis for gout flares needs to be considered on initiation of treatment, as it does with allopurinol. And so I think when people have been starting on urate lowering therapy, then some cover needs to be thought about. So prescribing febuxostat, usually you need an adequate trial of allopurinol and probenecid. Do not start febuxostat during acute attack, so probably the same advice as allopurinol, really. But as I say, there are probably some exceptions to that. Usual dose is to start at 80 milligrams a day, and to prescribe some prophylaxis with either low-dose colchicine or low-dose non-steroidal anti-inflammatory when starting febuxostat. Monitor liver function tests, and encourage adherence to all urate lowering therapies. Now, this is the big problem, I think, with a lot of these things, is people sometimes do not understand that that these are to prevent future gout attacks, and they'll start feeling well, they've got over their acute attack of gout, and then they just stop taking them. And that's what we hear a lot from some of my clients. They don't really understand the importance of it. Benzbromarone, this is another uricosuric agent, which works by increasing the urate excretion via the kidney. There's some evidence that benzbromarone may be more an effective medication than allopurinol for people with Polynesian ancestry. So that's interesting in the New Zealand situation. But there are some concerns about rare but serious problems, liver problems, and that's led to actually benzbromarone being withdrawn in the US and some European Union countries. It is available in New Zealand under special authority criteria as a third-line treatment after allopurinol and probenecid. And there is prescriber information on the New Zealand Rheumatology website, which is down at the bottom of the screen here. Hopefully you can see that's a little bit blurry, but hopefully you'll be able to read that. And so there is some prescriber information there. So I remember one rheumatologist telling me that gout doesn't seem to come on its own. It seems to come with lots of other things as well. And so I think it's important to consider the CVD risk and metabolic syndrome for every patient with gout. So cardiovascular disease. There's an increase in recognition that asymptomatic hyperuricemia is an independent risk factor for the development of cardiovascular disease, but there's no current evidence that treatment of hyperuricemia reduces the risk of subsequent events. So that's quite interesting, I think. So well, that's led us on quite neatly, I think, to the these relatively new guidelines that have been issued by the British Society of Rheumatology in 2017. So these are, I think, probably the most up-to-date guidelines we've got. And there they are. That's where you can find them if you want to have a little look at those. So here are the recommendations, condense the recommendations down from those new guidelines. And the recommendations for management of acute attacks is to give the patient some education to treat the acute attacks as soon as they occur, and to continue established urate lowering therapy. So if someone's already on allopurinol, for example, and they get an acute attack, the advice should be to continue the allopurinol and probably take some anti-inflammatories, for example, as soon as possible. Affected joints should be rested and elevated and exposed in a cool environment. I know a lot of my clients say that actually putting something cold on an inflamed joint is really, really helpful. Treat with a non-steroidal anti-inflammatory or colchicine. And joint aspiration and injection of a corticosteroid are highly effective, particularly if you've got gout in one joint, or those people with acute illness and comorbidities. So when monotherapy is insufficient, combinations of treatment may be used. These are the new guidelines. But their recommendations for the optimal use of urate lowering therapies is that when people are starting on a urate lowering therapy, then it should be explained to them that it's there to continually prevent the return of gout, because I think some people sometimes don't grasp that message. Urate lowering therapy probably should be discussed and offered to patients who have a diagnosis of gout, especially those who have more than 2 attacks in 12 months. That I think that what most rheumatologists say, if people are having more than 2 attacks in a year, they should probably go onto a urate lowering therapy. Also, if they've got tophi or chronic gouty arthritis or joint damage, renal impairment, or kidney stones. So, but this is where the big change is really in the recommendations, is that these new guidelines state that the target serum urate should be 0.30 millimoles, and you probably remember me saying before that it's traditionally been 0.36. So we've got a lower target. And allopurinol is still the first line urate lowering therapy to consider, and it should be started at a low dose. The recommendations here between 50 and 100 milligrams a day, and then the dose increased at 100 milligram increments approximately every 4 weeks until the target serum urate has been achieved. Going up to a maximum dose of 900 milligrams, that's what they say in these guidelines, which is quite a big dose, if that's tolerated, of course. And then The other recommendations are for buxostat can be used as a second line xanthine oxidase inhibitor for patients in whom allopurinol is not tolerated or whose renal impairment prevents allopurinol dose escalation and sufficient to meet therapeutic target. So the recommendations for buxostat is to start with a dose of 80 milligrams daily, and if necessary, increase to 120 milligrams daily after 4 weeks to hopefully achieve the therapeutic target. The uric agents can be used for patients who are resistant to or intolerant of xanthine oxidase inhibitors in patients of normal or mildly impaired renal function. And colchicine, 500 micrograms once a day or twice a day should be considered as prophylaxis against acute attacks when you're either initiating or up titrating any uric lowering therapy. And continued up for 6 months is the recommendation. So for patients who can't tolerate colchicine, a low-dose non-steroidal anti-inflammatory or COX inhibitor with gastroprotection usually can be used as an alternative provided there are no contraindications. So some guidelines on when to refer to a rheumatologist. I'm sure most people with gout do not get to see a rheumatologist, but for those who've got whose gout is hard to manage, then it may be worth considering referring to a rheumatologist. So persistent hyperuricemia or gout attacks despite the maximum tolerate should be ULT, urate lowering therapy. So apologies there for the typo. If there's any doubt about the diagnosis, failure to achieve prompt resolution of acute attacks and development of progressive bone and joint damage on X-ray. So those are all probably indications that your patient might need a referral to a rheumatologist. And some lifestyle advice to patients there: try and maintain an ideal weight. Try and keep well hydrated, and recommendations should drink at least 2 liters of water per day. Exercise moderately, but when you've got an acute attack, just rest and elevate and cool an affected joint. And include some low-fat dairy. There is some evidence that low-fat dairy actually reduces serum urate, so that we like to encourage people to eat more of that. Soy, vegetable proteins, and foods high in vitamin C. And also, of course, some things to discourage, and that would be dehydration. Alcohol, particularly beer. People ask me a lot about alcohol, and beer is probably the worst thing. If you wanted to provoke a gout attack, then probably giving someone some beer might be the way to do it. And if the people can't avoid it, then hopefully they can limit their intake. Excess intake of purine-rich foods, so these are found a lot in red meat and offal, organ meats of an animal like liver and kidneys. Shellfish, oily fish, yeast extracts, so your Vegemite and Marmite are quite high in purines. Soft drinks containing sucrose and fructose, so anything really that's high in sucrose and fructose, because we know that there's some evidence that can interfere with excretion of urate. So, we try and advise our clients to watch their sugar intake, and that can be quite difficult, when you're looking at processed food, because a lot of that sugar is hidden. So that's a little bit of an overview of the 2017 British Society of Rheumatology guidelines. So I thought I'd move on. I'll talk about what Arthritis New Zealand can do for your patients, and to help you guys to manage patients with gout, and not only gout, of course, but any form of arthritis. So I'm not sure if you guys are aware of this, but Arthritis New Zealand has got a free helpline, and there it is. It's the 0800 number, and this is a toll-free. It doesn't cost the patient or client any money to phone that number, and they can phone it anywhere in New Zealand. So, and they will get to speak to us, and we can give them some advice about managing all these different sorts of arthritis. That's usually delivered by our Arthritis Educator service, so those are my colleagues. We've all got a health background, so we've got a reasonable understanding of helping patients to navigate through the health system. We're not there to take the place of you guys, the people, the clinicians out there, and people already looking at looking after people with gout. But what we do know is there's a time pressure a lot of the time. If you go and see a GP with gout, patient's probably got 15 minutes, and obviously there's a limit what you can do in 15 minutes. So, we can reiterate the advice, the clinical advice, and talk to our clients about self-management, things they can do themselves, which is probably what we're more focused on. We have got our website there, and there's a website address. We've got a newly diagnosed service as well. So for some forms of arthritis, we can actually put people in touch with other people who've been successfully managing that condition. So a lot of the time when they speak to a clinician, the clinician may know about the condition, but they probably don't know what it's like living with it. So actually talking to somebody who does can be very, very helpful. Support groups, we've got support groups dotted around the country. We have an advocacy service as well, where we can help people with various issues like, for example, ACC related issues with secondary osteoarthritis as a result of an injury, where having issues with ACC or work related issues, that sort of thing. Well, we can help people with that. And we also have a research fund. So any of you out there who want to do some arthritis related research, you can apply to Arthritis New Zealand for some funding. That's what our website looks like. This is quite an old screenshot, but yeah, you'll see that donate now. It's fundraising is really important for organisations like ours. But yeah, there's lots of information on our website, so people who've got access to the internet can find out a lot about our services there. And we appreciate not all our clients have got access to the internet. We've got interactive Facebook sessions. So this is a live Facebook discussion, which happens on a Monday night between 7 and 9 p.m. And here is one of my colleagues, Robin, in conversation with one of our clients on our Facebook page. So that's great. A lot of people like to use Facebook, and it's a really great way to interact with our clients. We do point of care testing, so we've got little uric acid meters we can actually take around with us and give people a readout of their serum urate, and that's quite useful. It's probably more useful as an engagement tool, really. But it's great, if you've got someone who's got a history of gout and the serum urate's way up there, we can say, well, look, you need to go back and talk to your GP about this, because obviously it means that you're more likely to have a gout attack if you can't get it down. So it's a great point. It's a great it's great to get involved with those conversations, and people usually like to know what their figures are, what their serum urate is. So we can certainly do that. And I know a lot of our pharmacy colleagues are doing this as well. There's some pharmacies out there who are actually using point of care testing and actually up titrating allopurinol at the same time. So I think that's a great initiative for those pharmacies who are doing that. These are some of our resources. Certainly not all of our resources. These are written pamphlets we've got out there. It might be a bit hard to see some of these. This says managing your pain. That says care of the feet. That says physical activity, and that says joint protection. So these are all related. These will all be relevant for people with gout. This one here is produced in collaboration with Pharmac, and it's available in lots of different languages. English, obviously, but also in Maori and Tongan Samoan and Niuean, I think. So we know that gout affects a lot of those communities, so it's great to have that in resource in those languages. The Stop Gout one. So if we talk to someone with gout, we will talk to them about what they can do to manage it, and have they seen the GP, and get into all those conversations. But we can also post them out, these resources. These are all free, so clients can ask for them directly. Health practitioners can ask for them as well, and so if any of you want to be provided with these resources, then just phone our 0800 number, and we can organise that. So there are some other resources out there. I'm just keeping an eye on the time, actually, seeing how we're going. So other resources out there. These are not Arthritis New Zealand resources, but they're very useful. Surprisingly, there are some apps now for managing gout. I think this is the problem is that some of these are American based, probably not that relevant to the New Zealand situation. But yeah, people can get apps for managing gout on the phone. Health Navigator is a fantastic resource, I think. They have actually got a health apps library on their website. So if you want to check out what apps are available for all these different sorts of conditions, then Health Navigator is a good place to go. And it's certainly something that I will direct my clients to if they have access to the internet, because there's lots and lots of information on there. So, you know, and I've happened to find this, which is obviously something related to what we're talking about today, gout, diet and weight loss. So Health Navigator is a fantastic resource for people out there. And there's the address for it, for those of you who don't know. And then there's these other resources as well. This is these are some of our information. These are the ones I mentioned before. The Stop Gout one, the out with Gout one, and those are listed here. So this is somewhere else you can get those gout resources from as well. So the web address is down at the bottom there. So yeah, the next poll question, which I hope Emily will pop up for us, is it's asking you guys about, you know, whether you've had any need to refer people to Arthritis New Zealand, or it's just asking, as a result of attending this webinar or taking part in it, would you be more likely to direct your patients to the Arthritis New Zealand services? So I'll give you guys a few seconds to fill that in. Fantastic. 95%. That's wonderful. So that's great, guys. And it just a reminder that the easy way to do that, to refer your clients, is to direct them to the 0800 number. I'll just put it back up on the screen if I can. There it is. So this is our 0800 number. It's as I say, it's a free call. It's the easiest way you can tell your clients to contact our organisation. It doesn't cost the client any money. They can call that number as often as they like. It's not manned 24 hours a day, so if people call that number at 4 o'clock in the morning, they're not going to speak to somebody then, but they'll be invited to leave their details, and one of us will contact them and talk to them. So it is a free service, and we just encourage all the practitioners out there to just let people be aware of that, because not everybody with arthritis is going to need to use us, but at least if they've got the number, then they have got the information. And we're not just talking about gout here, obviously. People with rheumatoid arthritis and osteoarthritis and fibromyalgia as well. There's a whole heap of conditions that we can talk to people about, and we have got information leaflets on most of the common forms of arthritis, and those leaflets are available on our website as well. So thank you for that. So
I'm just going to put in.
Yes.
We've got a couple of questions in Q&A. If you've got a couple of minutes to answer them, if you click into Q&A, you've got 2 questions in there.
Yes, fantastic. Thanks, Emily. I understand I've got 2 questions waiting, so I'll go and have a look. Okay, so the first question is from Anna. Is it safe for allopurinol to be calculated with estimated glomerular filtration rate, as this is an estimate and can overestimate renal function, especially in elderly, those with decreased muscle mass? I think that's what it says. That's a very good question, probably something I'm not really qualified to answer, to be honest, Anna. I would probably suggest that people talk to, if there's any questions of that nature, they'd probably talk to a rheumatologist and get their advice about that. I probably need to be a pharmacist or a rheumatologist to answer some of these questions, and I am neither, so I do apologise. The other one is, have the maximum doses of colchicine been changed, i.e. lower? I'm not sure about that. Some of you pharmacists out there may know that. So that's 2 questions from the same person. So I'm sorry, I can't really answer those questions, I'm afraid. But yeah, as I say, talking to a rheumatologist, getting rheumatologist advice, or a pharmacist around medication is something that we certainly would advise our clients to do. It's something sort of I couldn't really advise on, I'm afraid. So going back to the learning outcomes there, what I hope we've covered is an understanding of the factors that contribute to New Zealand having such a high incidence of gout. We looked at some of the genetic influences on that, and we had a look at the diagnostic criteria. So I think still the gold standard is joint aspiration if there's any doubt, and visualization of uric acid crystals on the polarized light, I think it is they use to show those, and an understanding of current guidelines around the treatment of acute gout, and an understanding of the current treat to target guidelines. So we talked that initially it was 0.36 millimoles a litre, now the British Society of Rheumatology have suggested 0.30, and an understanding of some of the support that can be offered by Arthritis New Zealand for patients with gout and for other forms of arthritis as well. So I hope we've covered that to some degree anyway. And I think we're probably nearing the end now. I'll just see if I can flip on to next. So yes, here are the references. So yeah, I mentioned Tony Merriman before. He's down here in Dunedin, and he's been doing some fantastic research with his team down here. I'll leave this on the screen. There is another page, but I'm hoping that you can record, see a recording of this and get these references if you need to refer to them yourselves. I'll just flip the next page up with the references, and there we go. So if any of you guys want to do a little bit more digging deeper into this, then there's probably some way you can look for the information. So thank you, everyone. I'm not sure how we're doing for time. I'll just check my phone. So we've got some time for questions, so thank you all very much for taking part in the webinar. I do appreciate it. I know it's quite late at night, but it's difficult to know when's the ideal time really. And I know for practicing, people in practice, that probably the evening is probably the best time. So that's why we decided to do it in the evening. So yeah, thank you all very much, and I'll just hang around to see if there are any questions that pop up. I'm just clicking on the Q&A there, and I'm not seeing any questions. Hopefully I've answered them.